Alu,
A
please
patient
start
was
the
on
video.
sepsis. There was acute renal failure. Hello all, I'm Dr. Suhasini from Kokilaben Dhirubhai Ambani Hospital. I'm going to talk about use of high frequency oscillatory ventilation in the pediatric cardiac surgery, a case report. 5 months old male child weighing 3.5 kg. His weight is less than 50th percentile for the age. He was diagnosed case of left congenital diaphragmatic hernia with large ostium secundum AST with severe pulmonary hypertension. He was presented with acute respiratory distress syndrome. There was a progressive deterioration on the conventional ventilation and hence required HFOV. The other associated risk factors were patient was in sepsis, there was acute renal failure and he was in diuresis phase. He was a syndromic child with cleft palate and anticipated difficult intubation. He was severely malnourished. As we were unable to wean from the HFOV, the case was discussed in the multidisciplinary cath meet and decision was taken to go ahead with fenestrated ASD closure with repair of CDH. This case of having challenges at multiple levels, starting from the transportation of the patient, as discontinuation of HFOV could have proved fatal. So we have got a plan A, as to reassess whether patient can tolerate tube and back ventilation for a brief period of time till transported to the operation room. Or plan B, to initiate VA ECMO in perioperative period in NICU if patient doesn't tolerate discontinuation of HFOV with significant hemodynamic perturbations. We went ahead with the plan A. Patient was given trial of tube plus back ventilation and we monitored hemodynamics closely with serial blood gas investigations. Patient was shifted to the OR with tube plus back ventilation and reverted to the HFOV with settings of MAP of 12, delta P of 42, FR2 of 40%, IS to E ratio of 1:2 and frequency of 9. The adequacy of ventilation is confirmed with serial blood gas investigations. So here we can see the blood gas investigations before CPB and after CPB. So the adequacy of gaseous exchange is confirmed. We targeted mild hypercapnia with as much as low FiO2 possible. Serial ABGs are mandatory. Use of NRS for monitoring of regional cerebral oxygen perfusion optimizes the safety. Anesthesia in this case was maintained with total intravenous anesthesia with fentanyl and midazolam, as use of inhalation anesthetics was not possible because of HFOV. Patient had single uneventful CPB run with duration of 128 minutes with cross-clamp time of 83 minutes. Patient was reverted to HFOV with the previous setting after termination of CPB. HFOV was continued in the post-operative period and was gradually weaned to the conventional ventilation. Though patient has got prolonged and eventful pediatric cardiac ICU stay, patient was discharged on post-op day 45. High-frequency oscillatory ventilation is a mixed blessing. In this scenario, especially in patients with congenital diaphragmatic hernia, because of impaired lung compliance, ventilation with conventional ventilator may not be sufficient to maintain the adequate gaseous exchange and so oxygenation, and hence the HFOV is a savior. But also it has got some drawbacks like the non-familiarity with this unique mode of ventilation, limitations posed because of the hindrance in clinical examination, inability to use basic monitoring techniques like capnography, limited patient-derived parameters. We need to rely mainly on the ABGs for the adequacy of ventilation and modification of anesthesia technique to the TIVA, as we are not able to use inhalation anesthetic agent in this scenario. So here, intraoperative management is demanding even with the expertise. HFOE provides better gaseous exchange and oxygenation in patients with CDH, with poor lung compliance and with severe pulmonary hypertension. Transportation of these 6 substances arduous, even with vigilant monitoring of hemodynamics, and also it takes the clinical judgments. ECMO must be available while dealing with these high-risk substrates. It is mandatory to go ahead with serial ABGs as it is the only way to check for the adequacy of gaseous exchange. There is a constant threat of pneumothorax when the HFOV settings are escalated. Continuous use of NIRS is essential, especially to check the cerebral regional perfusion. Though this technique is not so familiar, but it's a rescuer in this type of clinical scenarios where the lung compliance is extremely poor. Thank you.